Hey there, and welcome to Immune Matters, the podcast sponsored by the PIDTC, where we dive into immune deficiency and dysregulation. I'm Dr. Jack McDonnell, a pediatric immunologist at Cleveland Clinic.
I'm Dr. Elie Haddad, an immunologist and bone marrow transplantation scientist at CHU Saint-Justine with a French accent in Montreal. We both care a lot about rare immune conditions and the people living with them. And in this podcast, we're excited to bring you the latest groundbreaking research and insights from the field.
And Elie, I know we've talked, another major goal of ours is to highlight the patient experience, not just things from the doctor's perspective. So we're going to feature several episodes that center the patient's voice and explore the immune disease from their perspective. So just a reminder, this is a podcast for educational purposes only. It's not medical advice, and the views expressed here don't necessarily reflect those of the PIDTC, the NIH, or our individual institutions.
And whether you're a provider, a patient, or just curious about the immune system, we are glad you're here. And now, let's get started.
And now we're really excited to welcome Dr. Jen Heimall to the podcast. She is an acknowledged expert on severe combined immune deficiency. Dr. Heimall, can you please just tell us about yourself?
Sure. So hi, my name's Jen Heimall. I am at the Children's Hospital of Philadelphia, where I've been a practicing clinical immunologist and allergist for the last 15 years. And I work very closely with our transplant team to take care of patients with a broad range of immunodeficiencies. But I've also had the great privilege to work with the Primary Immune Deficiency Treatment Consortium in the work to really kind of better define outcomes for SCID over that time as well.
Well, it's great to have you. Thanks for agreeing
having me.
to do this. So Elie and I always like to start out by asking a little bit about the disease that we're talking about. And of course, many of our listeners are coming from different backgrounds. Not all of them are physicians or immunologists. Could you just kind of tell us about SCID? What do we need to know, kind of the basics?
Yeah. So I think when I think about SCID, and I'm trying to describe it to a family for the very first time, I really describe it as kind of being exactly what it says that it is. It is kind of our most severe form of immune deficiency. And it's one of the few diagnoses in immunology that'll get our blood pressure up and us running down the hall to need to take care of patients. We're really fortunate that over the last 15 years, newborn screening has let us be able to diagnose babies with this disease before they get sick. But it is a disease where usually within the first year of life, we really have to put on very careful protective measures to keep the patient safe. The family has to invest a lot of time and effort to participate in that. And then, the main treatment for most patients is hematopoietic stem cell or bone marrow transplant. And that's where we spend a lot of our time talking about how we're going to safely get to that definitive therapy.
I mean, so if I'm a new family whose kid is being diagnosed with SCID, take me through the process. I'm sure they'd have a lot of questions. First of all, how might it be diagnosed in the first place?
Yeah. So, most commonly when I'm meeting families for the first time, they are coming to us because they had an abnormal state newborn screen. So when all babies are born, they have a heel prick that's collected, a little spot of blood gets collected, and then the state, or if you're in Canada, the province, will do testing for a whole bunch of disorders that might not otherwise have symptoms very early on, but can have really severe consequences, and SCID is one of those. And so the first step that we always do is to have the result of that newborn screen, but then we have to do an actual blood draw to count the number of immune cells in the blood. Because what's wrong in SCID is that there are low numbers of a particular kind of immune cell called T cells. And so if you think of your immune system as kind of like the army that's trying to keep your body safe from severe infections, The T cell part of that army are kind of like your special ops that go through a lot of training and need to be taught how to recognize, not to destroy yourself, but also fight off the invaders. And so if we don't go through all the right steps of development for T cells, we can have big problems. And so there are a lot of different forms of SCID, but the first thing we always do is just do a test called flow cytometry to check that those special ops, that those T cells and some of the other special ops kind of cells called B cells and natural killer cells that they work with are present in normal numbers.
That's funny that you use the army, because I use the same and I was smiling because of that. And me, I describe the T cells as the CIA. Because,
Yeah, there you
we
go.
have the intelligence, they collaborate with everyone, they give the orders, they can kill if they need to kill. So that's funny.
That's a great
We
analogy.
minds thinking alike there.
Yeah. Do you speak also about the bubble boy? Because, SCID has been during many years related to this story, and with the movie of John Travolta, and with the sad story of this boy from Texas, Houston, Texas, and also in France. I can tell you, we used the bubble boys during many years. Sorry, not bubble boy. Do you also quote that, or you don't speak about it?
Yeah, when I first kind of started, I used to talk about the bubble boy story, but I have found that over time people kind of didn't get that as well as the military analogy.
Yeah. It's more
So,
it's generational. The bubble boy is more for people old like me. The young ones don't have.
and me too.
Yeah,
And me.
they don't have. Sorry,
Yeah.
they don't have this reference anymore. So fine.
I think, Elie, you're totally right that like that concept of the bubble boy and how much we learned from that experience and the experience of many families who kind of walked this walk before. It's why we have newborn screening, and we have the good fortune to have so many patients that we're able to treat before they're sick. And I think that but it also makes it more challenging to try to really explain why this totally, generally perfectly healthy appearing baby now needs to be kept away from their toddler siblings and can't go to daycare, and the parents can't have all kinds of visitors. You can't have different, like if you were going to have a bris or a baptism, you got to keep those really small. All those kind of things are those like life details are what we do spend a lot of time talking about, how to keep the baby safe. And there's a lot of discussion of like, what's the best place for that? Is it in the hospital? Is it in your home? And it's a very patient by patient specific discussion that we have. But we are fortunate, at our institution, that we really protocolize how we do that first visit. And I think a lot of places have kind of protocolized that first visit. And so that counting of the T cells and the B cells and those natural killer cells that are part of either the CIA or your special ops, whichever part of the military you want to pick. But we have to check that the T cells are also developing normally. And I think that's for all the clinicians who might be listening, if you're ever in a position where you're trying to order those tests or you're talking with someone about it, we don't want to just check that you have a normal number of T cells. That's not enough. We have to know that those T cells have developed normally, and that the vast majority of the T cells in a baby are immature or naive T cells. We don't want a whole lot of memory or old T cells. They're a baby. They should be figuring stuff out, and their T cells should be figuring stuff out too. So I think that's one like really important pearl that I think it's important for all the clinicians out there to be aware of, that we have to look at those developmental stages. And that can be a harder test to find, at different commercial labs. So partnering with folks who can help give you guidance on where you can get that done is like super important.
So
You tell also the parents how the babies would have presented if they were not diagnosed by newborn screening, or what is the natural history without transplantation?
Yeah, unfortunately, it's really very sad, and I am sadly old enough to be able to think back on patients earlier in my career who didn't have the benefit of newborn screening. And, they can present usually somewhere between 4 to 8 months of life. They get their first cold. They've gone to daycare. They have little, older brothers or sisters that live in their home, what have you, and they get their first cold, and it settles in, most commonly it would settle into their chest. and then they develop severe respiratory infections, oftentimes on a ventilator. They may have failure to thrive or poor weight gain from chronic diarrhea or not being able to clear, GI or gastrointestinal infections. And unfortunately, if we are not able to successfully transplant, which is so much harder to do once you have infection on board, these patients will usually pass away by the time they're 1 year old. And that's why it is just so important that we get to transplant fast and we get to transplant without infection.
So when you
Sounds
say
like-
fast,
Yeah.
how fast? What do you sell? Excuse me, the expression said, but how do you explain the parents the fact that it has to go fast, but not too fast because
Right. Yeah.
Tell us again.
Yeah. So, we want the patients to be transplanted usually within the first 3.5 months of life. That is our target time to transplant by. And it takes time to walk through the transplant process. You can't walk into clinic and expect to have a transplant the next day. There's a whole process we have to go through to check. So on the outside of every cell in our body, there's a little bit of flare that says this is who you are. And that's how your immune cells, these are called your MHC complexes. Your immune cells recognize that flare and don't react against it if they are trained appropriately. And T cells are particularly important in that recognition of self versus not self. So we have to make sure that we check the baby's markers, their MHCs or their flare. And then if they have siblings, that is our best potential donor. So we always, once we've made a diagnosis of severe combined immunodeficiency, we always get cooking at the same time, the HLA typing for the baby and the HLA typing for both their siblings, which need to be full siblings, so same mom, same dad, and their parents, because in our institution, we will very commonly use a half-matched parent donor with very specific techniques to remove mom or dad's T cells so that they don't react against the baby's flare, so to speak, because those T cells are the bad actors to cause problems down the road.
So you say that the best window is 3.5 months.
Yeah. And that HLA typing, it's going to vary by where you are and, how fast the lab that they work with can get results back. So in some places, you'll get results in 5 days. In some places, you're going to get results in 2 weeks. But that's okay, because at the same time as we bring the patient in to get that HLA typing cooked, we are usually also drawing blood from the baby to figure out what particular genetic form of SCID they have. Because SCID is a genetic disease. It's generally going to be, in 30% of the cases, especially for boys, it's going to be passed down from mom as X-linked SCID. But there may or may not be any family history. I have run into so many families where there's no family history, so you can't go on a negative family history being reassuring. But knowing and so you might say, well, what do we care about the genetic history then? But the genetic history for the patient helps guide us in terms of what the prognosis is after transplant. It helps guide us in maybe how to approach the transplant for the best chance of success, and thinking about how we prepare the infant with medicine to best accept the stem cell transplant. And there are a few forms of SCID where we can also talk to collaborators that are experts in the field working on gene therapy, and see if those may be options, depending on the family's thoughts about participating in research, because most gene therapy, at least in North America, is only available on a research basis currently. And then finally, there's one particular form of SCID called ADA SCID, where if we find that diagnosis, there is actually a medication that can help to temporarily correct the immune deficiency and reduce the risk of some of the non-immune system effects like hearing loss and kind of developmental challenges that can be more commonly seen in patients with ADA SCID. So if we find that genetic cause, we will typically start those patients on a medicine called Rocovy, that is an enzyme replacement therapy, specifically only for that form of genetic SCID.
Thanks for briefing us on that. We would love to hear from you about some of the research you've done in this area, because I know there's a lot of amazing studies that have really kind of made it from a diagnosis of severe combined immune deficiency, which was not compatible with life for very long, unfortunately, to today's day and age when these patients are often doing quite well. Can you tell us about some of the research you've done, in particular, if some of it involved the PIDTC?
Of course. Yeah. I think the vast majority of my research is clinical and collaborative, and the PIDTC has been a major factor in advancing the field of severe combined immune deficiency clinical outcomes awareness and advancing, I think, health authorities' awareness of the importance of newborn screening. So I like to highlight one of the most recent papers by the PIDTC that came out in 2023 that really demonstrated, looking over decades of children who were transplanted, that having newborn screening is significantly associated with better long-term. And when we're talking about SCID right now, we're mostly talking about long-term, meaning 5 year, because that's how long we follow the data in most databases. But I think in that study, newborn screening was so important to really raise the bar for improved survival. I think other important work that I'm particularly proud of is really the work that we did with PIDTC's database of patients going back to transplants from many years ago now, and looking at later outcomes in those patients. And what we found is that there is just such an importance for ongoing follow-up of those patients for sustained immune function to after transplant, to make sure that we're monitoring that the T cells are working correctly, that they're talking with those other immune cells that I mentioned before called B cells, to make good immune proteins to be able to continue to fight off infections well. But we also found in that study that while patients generally are doing very well surviving, we do see that there are some patients who continue to develop some late effects, or that the late effects will present up to 15 years after transplant. And some of the most common ones that we saw were related to an underlying genotype. So patients who had a particular gene called Artemis SCID, which is one of the more challenging forms of SCID to transplant, because there's a fragility to the DNA that makes them less able to handle some of the chemotherapy-based conditioning that is needed in transplant. So those patients had higher risks of nutritional problems, endocrine problems, dental problems. I had mentioned before that X-linked SCID is one of the most common forms, and I think one of the things that we continue to struggle with is the best approach to transplanting these patients for optimal immune recovery. And so in them, what we found is that there continues to be relatively higher rates of needing to stay on a medicine called immunoglobulin replacement therapy in that late effects paper. But on the positive side, what this means is that the vast majority of patients are very healthy, even up to 15 years post-transplant, and that they are doing well. I think in terms of future directions, we need to be able to do a better job at following these patients late into life, and having kind of a broad understanding of what things really help us predict who may or may not be at higher risk of having problems as they get older. But I think those are probably what I would highlight to start. I think PIDTC has been seminal in general with the collaborative work of centers across the United States and Canada in demonstrating that being transplanted before you have infection, being transplanted by those 3.5 months, being being aware of which particular gene we're transplanting for and how that impacts on long-term outcomes. I think that is all great work that has all been done by the PIDTC over their 15 years of really fantastic work, including a seminal paper really looking at the outcomes in patients with ADA SCID as well.
I love that word collaborative that you used, because it seems to me that really is a huge thing that something like the PIDTC offers in a situation in which a disease is extremely rare. Maybe many centers might not see very many cases of this. Working collaboratively, it seems like a good way to learn from everybody.
It's the only way.
So right, Jack. I think there is no way that any of us, I think, would know what we know without talking to each other. Taking care of babies with SCID is a team sport. You cannot do it alone and do a good job. They're complex. They have a lot going on. And every patient, even from you think until they have a curveball in their road, or a curve in their road rather. Maybe it's a curveball too. That would be doubly bad. And then you call, I call Elie, or I call my colleagues at UCSF, or my colleagues at Cincinnati, or my colleagues from the NIH, and I talk to them about what would you do in this situation, because as much as we do have increasing amounts of data about these patients, so much still is individualized to the patient.
Absolutely.
It's humbling.
Those are the positive aspects. And for you, what do you think is the most urgent unanswered question in SCID care or SCID biology?
I think there are a lot of competing urgent questions, frankly. I think there are things about best approaches to clinical care that are still to be defined. Could we come up with a best approach to pre-transplant management that could be truly standardized, a best approach to handling newborn screening that could be truly standardized across the United States and Canada and even beyond, to really get to the best. And I think that that's something that the current PIDTC protocol is trying to look at. Are there certain best practices that could really help us understand that? Similarly, I think we also don't understand besides, we all presume matched sibling, like I mentioned before, is the best potential donor. And I think that that is probably true. But what are the best options with modern techniques for thinking about our graft sources? What is the most successful way to approach transplant in terms of conditioning, in terms of donor source, in terms of donor T cell depletion, in terms of donor, selection. Yeah, I think those are the ones. I didn't have another one, even though I had another finger out. And then I think also, like I mentioned before, what are really the main things we need to do to optimize long-term success? So like in terms of thinking about trying to prevent graft versus host, where T cells that came along for the ride with the transplant now are reacting against that flare or those MHCs on the patient, we still see more GVHD than we want to see in patient, because any GVHD is bad. What's the best way to avoid it while also optimizing success for long-term T cell reconstitution? Because I think we are still seeing that there are some patients who have this drift downward of their T cell counts as they get older. And we see that sometimes in unconditioned or minimally conditioned states, but we have to balance how much conditioning is really needed. So those are the things.
I have another one, and I think this one is a curved one.
Okay.
There was a paradox in what you said. You said you think that each baby is different, each patient is different, and we have to take care of individual with one specific gene, one specific mutation. And in another question, you said we should all have the same protocol in order to have the same way of doing things. So please, close this contradiction.
Yes. So, I think that pre-transplant, there are some things that need to be universal. some elements. Not everyone should get enzyme replacement therapy, clearly, but like, some elements of how to prevent infection are probably universal. And there are some elements of being able to protocolize what are going to be the most meaningful factors to monitor immune reconstitution over time.
Okay.
But by each patient being different, what I mean is that, we need more data about specific gene and what are the specific outcomes in detail. Do we need a higher dose of cells even to correct, say, a RAG patient versus a patient with other genetic forms of SCID? Do we need to, what is the best approach to treating maybe some of the pre-transplant inflammation that we see, and to have the least impact on later immune reconstitution? I think we extrapolate a lot of what we do in graft versus host management to try to address when we see pre-transplant inflammation, but I don't think there's any true standardized approach. So I think I could kind of reconcile it in that way.
That's okay. Not so curveball.
No,
Yeah.
not that bad.
You knocked it out of the park.
It wasn't a fast pitch
Yeah.
curveball.
So, Jen, I would like to transition into this is one of Elie's and my favorite parts of each podcast, is where we kind of ask you a little bit about some of the stuff that we won't read in the papers that you've learned about SCID along the way, or lessons you've learned from your studies or from patients and your experiences with them. What can you share with us about your journey taking care of patients with SCID?
Yeah. The patients teach us I learn something new from every family and every patient that I work with. And I think that no matter what, even if you as their provider think that this is going great, it's really, this is not bad at all. This is an extremely hard journey for every one of these families. Some of them seem like they're going through it great, but I think taking the time to really talk to people about their emotions and how they feel, and checking in at every visit, even when they're post-transplant. So it's not just the day of, okay, we got the abnormal newborn screen and your baby has this really pretty horrible disease that we have to treat them with a bone marrow transplant in the first half year of their life. But it's also they're now 5 years post-transplant, and maybe they haven't had the best immune reconstitution. It wasn't what they expected to have happen. Reconciling that and making them feel comfortable with that. Talking to the teenagers or the young adults when they're starting to think about going to college, or the young adults when they're thinking about going to their, have their own families, and wanting to talk through their own genetics themselves and having that conversation all over again can really open some difficult places for their families, I've learned. And so, really setting aside time to have those conversations, but to preemptively have those conversations. The teenagers often want to talk about what they're thinking about it. What is the impact if they got conditioning? What's the impact on that for them long-term, for their overall health, their lung health, their ability to go out and do things, and their ability to potentially have their own families. So those are all some of the later conversations that, I say it is a forever journey. And I love the partnership and the relationships that I have with every one of my families. It's why I do what I do.
Plus, sometimes I'm sure you also met this type of adolescent and patient who don't want to hear about it. Come on, yes. I'm not sick anymore. I don't want to see you. Just leave me alone.
Yes.
I love those ones too.
Yes, there are also the ones who are like, I got nothing wrong, but their parents are bringing up in clinic, like, oh, can you please tell them this is why they need to take their immunoglobulin? Or they are completely and totally healthy, but this is why they need to come to clinic and have blood work done. Any of those things.
It always struggled me when a patient who is not sick, he's doing very well, doesn't want to come to the doctor, doesn't want to be recalled that he's been sick, and they come back with questions. And sometimes I wonder if we really help them doing so. So you have to be very smooth in the way, because some patients want to feel cured. So that's completely understandable. So we have to find the good balance between letting go completely and continuing to do medicine and science, because that's what they need.
Yeah, you have to kind of read the room. And that's why you get to check in at least once. I really feel strongly about checking in once, even if we don't do blood work every year, but just to talk. How are you doing? How are things going with your life? Are you in school? Are you working? Are you, like, what is going on?
Absolutely.
And then you can help people.
Yeah,
Because
absolutely.
at its heart, that's why we're all doing.
Yeah.
Yeah, if you're counseling a new patient, something I always think about is patients have a lot of choices and decisions to make. They might have heard about this gene therapy that you discussed before, for example.
Yeah.
And it sounds like, I think to a patient, that sounds like pretty cool and maybe less severe than getting a bone marrow transplant.
Yeah.
Any thoughts you'd want to put in our heads about the role of gene therapy for SCID as opposed to bone marrow transplant?
Yeah.
Something that
Yeah.
might help our patients who are dealing with this new diagnosis themselves or for their loved ones.
So, I mean, I do think that this is where really knowing, obviously, what gene you're dealing with is so important. And I always start the conversation about what the potential treatment is in the context of what is your gene. So, I don't bring up gene therapy unless it's something that there is a
Relevant.
trial available. I think that there is a reality that there is, for many of the gene therapies, there is somewhat of a little bit of a waiting list, and you're probably going to have to go to the treatment center. So I think that that is something, if you want to be just close to home, if you want to be able to get your your treatment primarily right where you live, if you're, from Chicago or you're from, Wyoming, it's going to be a little bit harder to be very close to the places that I can think of off the top of my head that are doing gene therapy in North America. I think that being said, if I have a patient who has a gene, and the three genes that I think of as, trying to approach gene therapy in the United States are X-linked SCID, which is IL-2RG, ADA SCID, and Artemis SCID. So for any of those patients, we do talk about the fact that there are active gene therapy clinical trials, but they are that. It is, you have to be willing to participate in research. The flip side is that many times if you're getting a bone marrow transplant, you're participating in a natural history protocol. So, on some level, all cellular therapy has some element of constantly trying to advance the field. In gene therapy, I think we are still trying to figure out exactly what level of conditioning and dosing is needed. And I leave those conversations to the people who are actually doing the gene therapy. I don't try to get into it because that's not my area of expertise. So if the families are interested, most of the folks that I know who are doing gene therapy are very willing to have a virtual consult to begin with so that families aren't like flying to whatever, corner of the country in the United States it is. And so I think, in that regard, if they have an interest and a willingness to, participate with those very broad strokes, I then kind of set the wheels in motion to have an initial conversation. And then I really try to let the families guide what they think is best. I think there are some situations where it's going to be better than others. And, I think knowing what the donor source options for the family, for the patient also influences it because for most of the gene therapy protocols, I think if there's a matched sibling donor available, you won't be eligible for the research-based gene therapy. So I think that is an exclusion criteria, unless Elie has thought otherwise, because I could be wrong. I always do check.
No.
But
I don't know exactly if it's
okay.
a contradiction in all the exclusion criteria in all the protocols. What I wanted to say is that there is one disease for which I strongly advise gene therapy. It's Artemis SCID.
Yeah.
Although it is a research protocol, although because of the nature of the research protocol, you don't know the long term, you don't know many things. Still, the Artemis SCID without gene therapy is a tough one in bone marrow transplantation. And in this situation, I strongly advise for gene therapy. In the other situations, I do like you. I speak about gene therapy. I explain that it could be far away, all the things, but the only one where I strongly advise it's Artemis.
That's Artemis.
Just because it's so difficult.
Yeah.
Sometimes in the
Yeah,
transplant.
the outcome of Artemis, the bone marrow transplantation is complicated. The use of immunosuppression plus
It's more complicated.
myeloablation.
They have the higher rates of long-term late effects. It's true.
Yeah, and the GVH on top of that is a total mess. So you don't want GVH at all. So yes, it's the only one where, although it's still experimental, I say that the data that we have are strongly in favor of trying it if you can do it.
And that is the one, I agree with you, Elie, that from what I have heard, it seems like it's pretty fast to get a patient in for the Artemis
we had
trial.
the chance to send a patient from Montreal to UCSF, and it was not smooth, but it was relatively fast, and it went well. Yeah.
Well,
so
Jen,
I think that can help.
Yeah, amazing discussion today. Thank you so much for talking to us and our listeners and viewers about
Thank
severe
you very much.
Yeah, thank you very much for your expertise and your willingness to come on here.
Thank you so much for having me. I'm really so excited to be able to share and participate, and I hope people will find it helpful. And it's always good to see you.
Maybe we'll have you back sometime.
Okay, sounds fun.
That's all for today's episode of Immune Matters. A huge thank you to Jen for sharing her time, expertise, and stories with us. If you enjoyed this episode, be sure to subscribe and share it with anyone who might benefit, patients, colleagues, or friends. And as always, you can learn more about the PIDTC and find additional resources at PIDTC.org. Thanks for listening, and we'll see you next time. The Primary Immune Deficiency Treatment Consortium, PIDTC, is a part of the Rare Diseases Clinical Research Network of the Office of Rare Diseases Research, ORDR, National Center for Advancing Translational Sciences, NCATS, National Institutes of Health, NIH. This work was supported by the Division of Allergy, Immunology, and Transplantation, National Institute of Allergy and Infectious Diseases, DAIT, NIAID, and the ORDR under cooperative agreements U54AI082973 and U54-NS064808 and grants R13-AI094943 and 1R24AI184316-01. The content and opinions expressed are solely the responsibility of the authors and do not represent the official policy or position of the NIAID, ORDR, NCATS, NIH, HRSA, or any other agency of the U.S. government.